Well, hello, Revolutionaries. Welcome to another episode of the EmpoweRx podcast, Revolutionaries. I am thrilled to have an amazing guest with us today, Maggie Ortiz, a registered nurse. And she is truly a revolutionary, helping to support nurses nationwide with a really critical problem. And so, Maggie, welcome so much to the podcast. We're so excited to have you here. Please tell us a little bit about your background and how we got to where we are today talking.
Sure. Thank you for having me on. So I have been a nurse for 23 years. I started with my associate's degree as an RN. Then after about 16 years, most of us know that you're not really moving anywhere up if you don't have a bachelor's degree. So at the time, I had been practicing for 15 years. So I was like, I'm old. If I'm going to school, I'm doing a bridge. So I did my bachelor's to my master's. So I did in leadership. Well, I've never been in leadership. I'll never be in leadership, but I did my degree in leadership. And then I focused on procedural sedation. My thesis was written on procedural sedation because I felt like we were being abused in that setting and sedating patients unsafely. So I created a questionnaire, 8 questions that would discriminate whether a nurse should sedate an RN and or someone in the anesthesia department.
Interesting.
After I had been practicing for roughly about the same time I was going to school, I had spent some time at a board of nursing. I became an investigator for a board of nursing. I spent a short period of time there. I came back on out. I started doing some of my own research, finding out that most boards don't have any oversight. And let me just say that again, most boards have no oversight. I then started studying up administrative law, transitioned into becoming a civil expert. A legal nurse consultant reached out to me. They needed, I don't remember the case, cath lab, IC, whatever it was. So I transitioned to a civil expert, where then I realized, so I had practiced under administrative law as an investigator, then I moved to civil medical malpractice. So I was seeing that they were respectful of the constitutional right of due process, where administrative law wasn't. So my concerns why I left there were even further supported by what I was then learning by being an expert in civil litigation, where due process has to happen. So continued down the journey. So then I became an administrative expert. Then I became helping nurses and their legal team when they're under investigation. I became an advocate for nurses, creating advocates for nurses. I don't make it crazy. Going to the Capitol, bringing things to my representative's attention, making change grassroots that most people don't even know about, writing a bill for an ombudsman, advocating for workman's comp in my state and other states, because they were not passed during COVID. Only 13 states passed, where a nurse, a frontline provider, would be given workman's comp even though they showed up during the pandemic. So it just, my short time at the board really changed me. I wasn't 5 or come from a long family where nurses were at. And so I wasn't called to nursing. It wasn't until I left the board of nursing that I realized I'm not called to nursing. I'm called to nurses. I'm called to make real change. And when I started down this journey, I had no idea what I would uncover. And I don't stand alone. There are other highly educated people that know about all the stuff that I'm talking about. This is not new information, but it's stuff that it is affecting nurses. If you are sent to the board of nursing because it's retaliatory, because you did cause, there was a medication error, and now the board of nursing is not justly investigating you. So I got on a long tangent there. So, but I've been a critical care nurse for 23 years. I don't work at the bedside any longer. I left in 2021. Big mystery why. Everyone can guess.
Right.
But I'm not called to that space anymore. I'm called to make change. Before I take my last breath, every board will have some form of oversight. That's what I want for nurses, and that's what we deserve.
Excellent. Thanks for sharing that. That's fascinating that the boards don't have oversight. It's actually shocking new information for me. So thanks for sharing that. So just to recap some of these pieces. So went from bedside, now working as a nurse advocate, and you are a legal nurse consultant, but obviously not an attorney or anything like that. So you're providing consulting and services to help nurses understand this process of how the board works and what happens if you are reported to the board and how to navigate through that. Would that be an accurate kind of way to surmise or sum up what you're doing?
Yeah, and then the term also is advocate, because most attorneys are not nurses and or
Mhm.
don't provide nurses with what that means to be under investigation. So I've created tools like a 6-page handout. Number one, what is an allegation? Most nurses have no idea what that means. Number
Yes.
two, what is a complaint? Number three, so then that's comforting. It's 2 o'clock in the morning and you're not sleeping because you're under investigation by board of nursing and you're sick to your stomach. But then you go to that tool, and I've sent them like, 5 or 6 different handouts like that. And like, okay, Maggie talked about that. I understand what that means now.
Mhm.
Some of it is just not knowing about that process. We're not taught
Sure.
about this process. When we're in school, anything that we learn legal, it's like, what do I need to know for the test so I can regurgitate it for the test? Because I'm not a criminal. I'm a nurse. What do I need
Right.
to know for the test so I can move on with my nursing care plans? And but we don't dwell there. So that lack of education does cripple us if we do land in front of a board of nursing.
Right. Absolutely. I think that's really awesome. So, I was doing some research obviously prior to connecting. And then as I had shared with you, this hits home. I have a friend who's going through this right now. She's a nurse. She's an awesome individual, a real caregiver, is dedicated, to the profession for many years. And what was shocking to me was it was years after the complaint or was filed that she even found out about it. So she was practicing, had no idea anything was happening, and then boom, here we are in 2023, and she was like, "I can't get a job." And it like blindsided her. Is that common, Maggie? Because I was shocked by that.
Yes, and these are the sad stories that I've heard for the last decade. So if you said she can't find a job, so then that tells me that she's probably on what we call the wall of shame, nurses, NURSYS. Because if she can't find a job, it's because she's already been put on this website, even if she hasn't been through the whole process. So some of
Yes.
my concerns that I do talk about, not just me, but other people,
Mhm.
why am I formally charged or placed on nurses if I haven't even had my full investigative process? How is that due
Correct.
process? It's not.
Yeah.
And now these nurses reach out to me and they're sleeping in their car. Now they have, and again, how are you affording a lawyer? So I donate the majority of I crossed over to be an entrepreneur about 2 years ago. And most of the stuff that I do is for free for nurses because I can't have you sleeping in your car just because
Right.
I have a body of knowledge that maybe other people doesn't have. That's my gift to you. So
Mhm.
talking about even pivoting off what you said. So then I moved into teaching charting classes. And why does that matter? Because your friend that you're referencing, if it's related to her practice, and then we look at the charting, if her charting is sound around this practice, you know what, there is no case. But if her
Right.
documentation is not sound, then you know what, it's 2 years from now, tell me about this person. You don't remember this person. You've taken care of thousands of people. Why is
Right.
this one person significant to you? 99% of the time it's not going to be, unless it was a code, a child, something that implanted on you because it was so traumatic. But as a nurse, you take care of thousands of people in a year. You're not going to remember this case, but you know what you will fall back on? Your charting. So coming back to her, yes, an investigation can take several years. And let me tell you why. So when I was the investigator at the board, I had 200 to 300 cases. When you walk into your job, say I'm working in the ICU, I have 2 patients, right? When I walked into that modality, that workflow, I
Mhm.
could be at a trial one week. I could be opening up a case one day. I could be, responding to a nurse. So the workflow within the board is different. But not only that, you also want them to do their due diligence. If they get a complaint, then they have to look at the complaint. Then they send the nurse the allegation. That's where the um, allegation is created. They get a complaint that um, I don't want to use, one's not coming to me, a medication error. Let's just say a medication error. So the
Sure.
letter comes to you on or about uh, 12/12/2023, while you were working as an RN at Sunnyvale Hospital, Sunnyvale, Texas, you gave the wrong medication to patient NB, and then they want your response. These are the possible violations, and you get 30 days to respond. Then they also have to reach out to the hospital where you worked. Where did this originate? Now I need to call. I called the CNO and said, hey, I'm sending a subpoena for patient BN because I have to have the records. If this relates to a medication error, then I need to see the medical records.
Right.
So then the CNO has to go to medical records to let them know they have 30 days to respond. Then I may have to reach out to a witness. Then that person has 30-day respond. Then I already told you I have 200 to 300 cases in various stages.
Right.
So some of these I have to put to a side. Who is the nurse that's actually harming the patients?
Right.
If there was one, and there was a triage system. So patient A is more of an emergency than you are. And I'm overworked, I'm underpaid, I'm at an organization, right? So
Mm-hmm.
now it's 2 years of your life. So does that make a little
Right.
bit more sense why the process could possibly take a little bit longer?
Yeah, it makes complete sense. I think for sure. And just something I want to clarify, because again, during my research, I was looking like, it doesn't seem, and obviously I could be totally wrong, that there's like a national database about this. It's all state specific to that state board. Is that accurate?
Yes, ma'am. And so
Okay.
each
Wow.
state, just because, just like even when you look at like, there's like federal laws and state laws, the state is
Hmm.
never going to turn over allowing like the National Council of State Boards of Nursing is who the body is. Then
Hmm.
they tell each state to set up their own rules and regulations. And you bring up a good point. Not every state has what is considered a traditional board of nursing. I in Texas have a Texas board of nursing. California, it falls under the ALJ. Michigan, I believe it falls
Right.
under Health and Human Services. Or so every
Yeah.
state is different, and it does make it a little bit confusing. It's something that I think that there should be some national something set up where it's a board or it's under HHS or DHS, but figure it out. But that's yes, ma'am.
Yeah,
But
I was
also just
thinking.
to pause there, I apologize. I don't want to interrupt you
Oh,
because
no, that's okay.
just
Go
think
ahead.
about this because it made me think of something. If you fall under the ALJ, like in California, and then you decide to go all the way to a trial, who represents then the board of nursing at that trial? The ALJ.
Yeah. So there's a
I'm not
conflict
a
of
corporate person.
interest,
So,
right?
and
There's,
now clear conflict of interest,
yeah.
right? So
Mm-hmm.
how is that fair? And then now no one oversees them. So whom will you tell? Let me just take that a step further to make it even more horrible. So you go all the way to a trial for an administrative court that's called the State Office of Administrative Hearing, or often referred to as SOA. That's considered a trial for nurses, right? Is SOA.
Mm-hmm.
You get all the way there, that administrative judge never has the final say. Oh, let me repeat that again. That judge never has a final say. It is called a proposed decision, something I as well have grave concerns about.
Wow. Wow. There's so
Life
much to
hard.
unpack there. Yeah, there it's so, it's interesting. My journey into, the last 8 years, I actually went back to school to become a nurse and started working as a travel nurse recruiter. Um, and very similar to you, I saw what was going on. Obviously, very different industry, but all still related, all still
Yeah.
interconnected. And I was like, man, there's so much conflict of interest here. There's so much unethical stuff going on. I want to change it. And the nurses that I worked with were like, you shouldn't be a nurse. You need to go do this. So, like that calling. So, I can relate to that. But I just think it's so important, the work that you're doing. And
Thank
I
you.
think it's a common thing that I've seen with healthcare professionals, but specifically nurses, like they're all in, they're doing the bedside care, they're under a tremendous amount of stress, you know what I mean? Balancing work and their families and everything else. And it's so stressful, bedside nursing, I know. And it's like, they don't have time to do all this research, they don't even think about it until it's right in their face and something horrible has happened. And it's just so tragic. So I'm so glad to have this conversation with you. I just think it's so needed just to keep getting this information out there and repeating it over and over again. um So looking at just kind of circling back a little bit, like, so you have the allegation in there, you've
Yes.
got this long, process, it's bureaucratic, everybody's got so much on their plate, so that could take years to even get to the nurse. And then what was interesting to me, you mentioned nurses. So, as soon as my friend reached out to me and told me about this, I, of course, went on nurses and I wanted to see what's going on and read through the reporting. And it clearly says there that it's not impacting her right to practice. Like, they were like, oh, it's not impacting. Like, I read through it and I'm like, I wonder why you can't get a job.
Well,
But no one will hire her.
yes, because that's the first place that they look. They look
Yeah,
you up on nurses. They see that you're on nurses, and just think about it and just think about it from a business standpoint. Let's just put that aside and let's just step over here. You
sure.
own a business. You want to hire me. Then your underwriters come along and they're like, yes, hire Maggie, but your deductible went from 5,000 to 5 million. Absolutely, you can bring her on, but you do know she's a liability to your business. And so, as your underwriters who insure you, she is a risk to you. So we would love to have her. And so it makes it oftentimes difficult for an organization to hire you, or people just look at that, they're uneducated, unfortunately, and they're
Right.
like, this is scary, we don't know what's, and they don't even take the time to read the language of what it even says, or even to work with a nurse. So yes, and so every day, I could show you text after text. I oftentimes get this question. The first thing I tell them, I'm like, I know, love, remember when we talked about I may apply to a job, one or two jobs, and I may get a job. You're going to have to apply to 100 jobs possibly before you're going to get a job. It does make it harder. You always have to disclose on your application. If you do been disciplined, you can never lie about it. I've seen where the board of nursing goes back, and if you lied on an application, they do add that to your orders. They do
Sure.
seek this stuff out. So you cannot lie, and then you have to disclose that. And some people won't even bother with you.
Yeah. It's interesting. I don't know, because I've done a lot of provider vetting for in my recruiting career. So, do you see that
Nurse
there's a,
or doctor?
yeah, doctors,
Oh, well,
surgeons?
okay. Well, they don't care about the doctors. Nurses,
Well, yeah, that's what I was going to say is, do you see a double standard? Because I mean,
well,
I've
yes,
seen some egregious
yes.
provider reports and they're hired.
Well, and even if you look at the complaint process alone, let's just take the lens out a little bit more. If you go to the board, I'll just use Texas, the Texas Medical Board to file a complaint, it's like an act of God. All the hard stops, like you have to know like address, all this stuff. A nurse, you have to know nothing, nothing. Reporter,
Wow.
it's harder to report even a nurse. Now physicians all have insurance, nurses
Right.
don't. If you look at us as a population, we're less likely to have insurance, where doctors are loaded up. So no, there is for sure a double standard, but they also bring money to the organization, where we suck money from the organization, and I don't mean that, but that's how organizations see us.
Sure.
So they're willing to overlook the physician, because do you think a patient's going to look a physician up? No, they see that physician as money. That is it. They don't care if they have orders, unless it's, even if they, because again, they're contractors more often than not. So they're not taking on that liability to a certain degree. Now, there are organizations like Baylor where the physicians are actually employed by the organization, but
Sure.
most of them, the HCA, and I can just speak about my city, HCA, Seton, any of these, the doctors are contractors. So does that organization really own them per se? So are they really taking on that liability? Look at these language when they put out statements about the doctor. They'll say at the bottom, like the ones that were injecting the medications and stuff. Oh, the doctor doesn't work for us. How do they get around it? Because they're contractors. That's how they're able to say that. So they're
Interesting.
not taking on that responsibility. So great question.
Yeah, fascinating. And I actually, because what we do is, encourage nurses and healthcare professionals to work as local. I mean, that's why I always say, as a doctors have been doing this for decades. I was like, it's time for you all to be able to do it too.
Yep.
And so that's an interesting concept to kind of think about when you look at those things. And the insurance piece is really big, and I know that you're a big advocate of that. I always tell nurses and even allied health professionals, I'm like, it doesn't matter if you're a W-2 employee, you have to have your own coverage because at the end of the day, the hospital is going to pick the hospital's best interests and not yours. And that's exactly why physicians always, even if they are a W-2 physician, they're going to have their own coverage because it's their license. So I totally agree 100% with all that's really, really important. Just simple things you can do to protect yourself that, oftentimes just get overlooked. Um,
I agree.
Fascinating. So,
And we're
so
talking
let's,
about $10 a month here, sister. Nothing crazy.
yeah.
You know this. This is, and that's just to put. I like to put that out there because people think it's really unattainable. It's not. I
No.
tell people start with your own car and home insurance. So just
Mhm.
reach out to them. Just, I'm a nurse. Do you underwrite for XYZ? It's never going to be criminal. It's only going to be for a board of nursing attorney or a medical malpractice or civil attorney. That would
Mhm.
be what those would get you. But I'm 100% yes. Why you don't have it, I don't know.
Yeah, it's super important. And again, I've met nurses that learn the hard way, right?
Yes.
That just that, oh, I thought the hospital or the home agency was going to help me out. I'm like, no, unfortunately, that's just not the way the world works. So we have to be wise, and protect ourselves. Um, So let's talk about because you mentioned, nurses sucking the money from the system, which I totally get. That's the perception, but I love this new conversation about the Commission for Nursing Reimbursement, and I know that you're big involved in that conversation on LinkedIn where we met, and I'm really excited about this. This is something I don't think the general public doesn't know a lot about healthcare. That's one of the things I learned years ago when I just started to immerse myself in understanding the entire system. And it's kind of frightening since the system impacts all of our lives so much that we don't know a lot about it. But I know very early on I learned, that kind of nurses are like a line item, like along with bed sheets, not to be, crass, but I was shocked. I was absolutely shocked. So when I saw this new initiative, I was so excited. So I would love for you to share with myself and the audience what this is and how we can help support it.
So I cannot take any credit for this at all. This is some of the people championing it now. Rebecca Love got behind this, and she, I think, helped to form some of the coalition, so the commission. When I was
Hmm.
at a National Nurses Business Conference last summer, there was someone that was talking about it, and I did approach her. I'm just championing all this other stuff, but I'm all about this. I did write in articles I referenced on LinkedIn a year and a half ago where NPR put out these ridiculous bills. A nurse, or the bill was for an injection for $722.63. Who gave that injection? Oh, yes, it was a nurse. So then I wrote out, like, on average, a nurse works 12 hours, 3 shifts. So I did the math out for 52 weeks, doing average, and I gave the nurse a little bit more money, $45 an hour. Did the
Hmm.
hospital just one injection if she did an hour, what the math was? It was like millions, millions. It was, and this is just
Yeah.
one.
Yep.
So what I understand the commission to be is that they're trying to get these codes tied to nurses. So an NPI code tied to an RN to give, let's say, an injection or to give care. So Rebecca Love talks about, she was talking about one of her articles that uh, nurses used to be independently charging for their services. Is it wasn't until hospital became basically funded by some insurance or where the physicians saw that they could roll us into the room charge. And she talks about this like they did the hotel where
Hmm.
we were initially independently charging for our services, but then they moved that away from us and coupled that into us. So the commission is trying to get it to where the RN, I'm not talking about the NP, where the
Right.
RN can now bill for their services. So they're trying to get the research, the funding around, like, let's figure this out. Like, who assigned these codes? I believe it's the American Medical Association, and it's like a 5 or 7 person team, and not one nurse sits on this. Why? Why is there not a nurse practitioner? Why aren't there a couple RNs? This cannot be driven by the American Medical Association. This is not just them providing care. We're so far removed from the day and age or they're carrying a black bag around door to door. That has to stop. And our
Mhm.
healthcare systems are crumbling because nurses like myself are tired of the abuses, and one of those is pay. The pay
Right.
disparity with us is just, it's disgusting, and we're tired of it. So this commission is highlighting people that are actually assigned jobs and tasks that will be doing the research. So funding the research to make this happen so that it can be presented in a respectful manner. And they've already approached Congress. They've already sat in front of Congress and said, "This is, do you know about this? Because let me tell you about this," so that they
Mhm.
can get some recognition, and so there can be some, funding around researching the RN, getting an NPI tied to them so that they can reimburse. There's a place for this.
Wonderful. Excellent. I'm gonna be following this really closely, and I know it's great to, be connected. I encourage everyone in the audience, if you're not using LinkedIn as social media, it's a big thing that we encourage through our clinician entrepreneurship program, but it's such a great tool. I personally think it's the best social media that's really out there because there's so much really educational content, and you get to connect with all of these leaders that are making these differences and learn about these types of initiatives. So would definitely encourage everyone to check out Maggie on LinkedIn and
I,
definitely check out that project.
I agree. I'm just pivoting off that. I agree. Your audience on Facebook, TikTok, Instagram, wherever platforms you are way different than LinkedIn. It's a
Hmm.
totally different crowd. That is where I did meet people. Like, one of her people, Diane, found me on TikTok and connected me with Rebecca Love. Some of
Hmm.
these other creators on these other platforms, Mary Jan Duquette, Just Culture, I was just on her podcast. People like yourself. This is where you connect, and you know what it does? It rejuvenates your nurse soul. And nurses need that. Really, this is a different platform where you can be connected with other people and learn about nurse creators, different things happening in our environment. So I highly suggest it myself.
Yeah, awesome. And we'll definitely have all the ways to get connected with Maggie in the comments, so that everyone can do that easily. So let's talk a little bit. I mean, obviously, that commission, it's a great project, great initiative. We'll be following that closely. But we've hit on a couple key things just conversationally about the challenges with things going on in nursing. I think, we're all pretty acutely aware of them at this point, especially our audience. Where do you see the future of nursing? I mean, obviously, what my company's doing, it has a specific, bend towards empowering nurses and making sure that they're, kind of making more money is a big part of what we do and in that capacity. But we know that we have a huge shortage. We know that we have all these challenges, with burnout. Our younger generation of nurses are looking to leave. Some in school aren't even looking to start bedside nursing at all. So I'm curious where you see the future of nursing from, kind of two perspectives of where are we going if we stay on this one road, right, without some of these changes? And then what changes can we see, what turn can we make to improve the future of nursing?
If we continue down the same current path, we will continue to see what's happening. Systems are failing. People are not coming back to the bedside, and healthcare will crumble. We are the largest workforce. We do provide the care. There's just no way around it. And it's taken till 2023, where we're just now, getting there. And let's just be real clear. I don't want it to crumble, but it will.
Sure.
They've ignored us. So hospitals will have to close. Some of these freestanding emergency rooms, surgery centers, these things that are solely based on just profit and greed will have to go away
Mhm.
until we refigure it out, because we have just abused us for too long.
Mhm.
The day and the age where like our parents stayed in one job, that doesn't happen.
Yeah, it's over. I know.
So if you don't invest in these nurses, and that means a year residency program, because these nurses post COVID, that's scary as well. The governors in every state had to overturn in-person clinicals, or no one would have graduated. So the board of nursing took no responsibility. These institutions took no responsibility. They literally pushed nurses out who'd never touched a patient. And now
Yeah.
on the back end, you know what I'm seeing? Nurses under investigation, because now we haven't done our due diligence and taken any responsibility to say, hey, we had to overturn this. So now what are we going to do? Now all hospitals or organizations have to offer a year residency program. That's not happening. So we've not even, and we don't invest in nurses. I hear all the time, and if you follow me on the any social media platforms, like an organization is giving us a gift of an orientation. No, the Nurse Practice Act requires you to give it to me, because there's a difference between orientation and training. And my training is different as a new grad who got did never touch a patient. And it's your responsibility as the organization to do your due diligence to see what my needs are and to then meet my needs so that you're safely providing care, again, dictated under the Nurse Practice Act for the CNO. But it's their responsibility to invest in my orientation and training. It's not a gift to me. I hear nurses saying that they've never gotten any orientation. That's disgusting. That's ugly. That's disgusting. And that violates every code of ethic, the rules and regulations. So that I'm seeing, I'm hearing, and if we don't auto correct and make some of these changes, again, why would a nurse become a nurse? Cases like, Redonda, or, some of these other ones in the media where nurses are wearing ankle bracelets because they just showed up to provide safe care, and now they're being criminally charged. If we don't get some of that under wraps, we don't figure out just culture, and every board has language. It cannot just be the North Carolina Board of Nursing, because the ANA has put out specific position statements to say that every state will adhere to just culture. I'm here to tell you that's not happening. So we have to see some of these changes. We have to start auto-correcting. AI is moving into our world. I don't really know what that means moving forward, but it's a huge piece. It will be a huge piece of what we do. So what does that look like? Where is the place for AI for the bedside nurse? I don't know. Maybe it's a piece of some documentation tools that you're able to verbally speak into your, let's say, Vocera, instead of scribing what you do. You know what I mean? So for better time efficiency, but keeping in mind HIPAA, you have to be careful where you're at and you're speaking into this. But what did I talk about early on? Defending your license will come down to documentation. This would be a gift. If someone, and I'm giving someone a business gift here, figures out how to, like doctors do, have like a scribe or something, right? And then you are giving yourself credit for all the stuff that you do. You walked in, you give a blanket, all the words, went and gave a blanket, or your badge, that badge tracker that you're wearing, cha-ching, cha-ching, every time you walk in, that's deposited into the medical record, further giving you credit, part of the whole commission, figuring out how we bill. But we're going to have to figure out AI. We're going to have to figure out investing into nurses, into a true, what I think is a residency program. We got to have some additional, I'm not huge on rules and regulations, but the travel industry has to be regulated. That has to happen. I know that the Hospital Association of California petitioned Congress and early on in 2020, because guess why? Everyone knows, because these travel agencies were being, hospitals and the travel agencies were being abused. So, where to start, sister? That's a hard, it's not just one piece. We do have to own our piece of it. We have stood here, and I say this loosely, not shaming anyone or saying, this loosely, because just like you talked about, we're just trying to show up and take care of people, but we've also stood by and done nothing and let our environment change and then dictate the rules and stuff in our lives. And we've not filed OSHA complaints. We've not filed complaints against our leaders. We've not filed complaints with CMS. There are people like Sarah Collins and Sarah Collins and Marion Weber who filed complaints against these organizations, that they've had to go to extremes. You have that ER nurse who had to call 911 when she wasn't getting any help. You have that other HCA nurse out of Florida who did have to take civil litigation, but then had to sign, because she took a deal. But it will have to be nurses who do the hard work. That more often than not, they don't want to do the hard work, because just like you said, they have families, they just want to show up and take care of people. But if we don't do that hard work, nothing will ever change for us.
Absolutely. Absolutely. I can't agree more with the statement. I mean, there's so many things that have to be done, and that's where I really think collaboration is so important, that we're all working uniformly towards the same goals, but in our own little lanes, collaborating, but like our thing is the whole travel biz and getting that under wraps and figuring out alternatives for hospitals that really benefit the clinicians instead of the third party agencies that just make billions of dollars. I think there's something to be done there. And that's what we're doing, and advocating and educating like you're doing. And then all the other players, that are out there just all working together. Because I think there is a lot of things that are question mark. I think this AI thing, like you mentioned, I think there's a great opportunity for workflow, like you said, but I also think that there's some cautions, that we have to really take a look. So it's slow and steady and working together just to really collaborate to figure out how to use all these tools and how to all come together for the same goal of empowering these folks and keeping them bedside safely, effectively, as well as for the patients. So I think that that's all very well said. So, anything important, Maggie, as we look to wrap up here, that you want the audience to know, as far as kind of basic steps or things? Obviously, they can reach out to you. That would be great if they have any questions or want to take some of your great courses. But just kind of any final thoughts or, things that you want to leave the audience with, that you think are key.
Well, we touched on several of those. Getting insurance to protect yourself. You have to tell no one. All that stuff is ridiculous. I encourage you to do that. Of course, learning how to chart, because in all those three courts of law, civil, criminal, administrative, it will come down to what you did or did not chart. I've been deposed. I've seen nurses deposed. I've been seeing civil, criminal, and administrative, and now it's on the big screen and go. And I've seen it now. You didn't chart stuff, or it looks horrible, or you using words that are just like apparently the patient. No. So charting is huge. It's something that's undervalued. We don't learn in school. You talk about empowering, and yes, we have to own some of the, our own licensure, our own
Right.
education. Part of that empowering yourself is your own path as well. If you're
Yeah.
in a place and it's not safe, why are you there? Why are
Mhm.
you there? And that's easy for me to say, but you just talked about your friend who was under investigation by a board of nursing. I can tell you countless people, one of those being that got an ankle bracelet off, was charged criminally, and was just a travel nurse, showed up to an assignment, did not know it was unsafe. But you have to say no. If you cannot take an unsafe assignment. I can tell you Texas 21711, 1S is the person making the assignment, T is me accepting the assignment. The definition of medical malpractice is knowingly and willingly taking on an unsafe assignment. All things I teach about. So then you use that in a respectful manner to your leadership. You're part of the solution and never the problem. And if they're trying to triple you up in the unit, you ask them, are you asking me to violate 217? S is you making that assignment. T is me accepting it, and in medical malpractice. They walk away from me. Just kidding, Maggie. That's what I thought. And then I asked the attorney for the Texas Nurses Association the last time I went to a meeting, and that very question, hey, sir, if a nurse knowingly and willingly, let's say on the ICU, takes an unsafe assignment, takes three patients instead of two, is that the definition of medical malpractice? Yes. They're gasping in the audience. I said, please repeat that for the nurses. If a nurse knowingly and willingly takes on, and just know when you take that assignment, you are accepting that knowingly and willingly, because you'll be asked to put up your right hand and say, what did you do? And you cannot say in front of the board of nursing that they told me. 1514 in my state says that my duty is to the patient, that supersedes a hospital policy or a physician order. And I just quoted that. So knowledge is power. The more you know and understand about the rules and regulations. Pivoting into number 4 thing that I think that you should know is 3 sections of the rules and regulations. And I encourage everyone to write this down. I talk about this in videos. You don't need to know how a school gets approved. You don't need to know some of this extraneous stuff about a board of nursing. You need to know standard of practice, unprofessional conduct, and grounds for discipline. You can go to Cornell Law, and you said, tell me, Tennessee, you can go Cornell Law, Tennessee, standards of practice, and it'll dumb it down for you. It'll just bring you that section. You can go to Cornell Law, Unprofessional Conduct, Tennessee. You can insert any state. So I teach nurses how to do that look up that. You can also go to the National Council for State Boards of Nursing. You can look up the Nurse Practice Act. It'll bring up a map of the United States. Click on your state, or it'll bring a drop down. Click on your state and it'll take you to the rules and regulations. So you, number one, says that you will know and adhere to them. So you cannot say in front of the Board of Nursing, I didn't know that, because then are you really telling the Board of Nursing that you didn't know the rules and regulations? You probably don't want to say that to them. So those are just the things that I highly suggest that nurses do. And then again, if you're not in a place that's supporting your education, supporting your orientation, then find somewhere else. You're magical. You're a nurse. I guarantee you, you'll have another job within 5 minutes. Don't stay at a place where you're potentially going to be put in a bad situation. And I'll just leave you with this last little nugget. The last time I testified, I didn't even have to say any words for a nurse sitting there in the breakout room with her, the attorney, the two judges. The judge asked the nurse, like, why do you think you're here? Because it was disgusting, because it was just, you know, we just kind of whittled it away. She said retaliation. The judge said to all of us, I oftentimes see nurses here due to retaliation.
Right. Yeah, I think that's a big part of what's going on in the field, just from my research, for sure. And I think people are afraid to speak out and step up. So great words of encouragement and empowerment. I can't thank you enough, Maggie, for this. This has just been awesome. I've learned so much, and we can take some of this and start to also kind of feed it out to the community with, you know, to make sure that we're understanding how we can further empower and educate people in our community through learning from you. So thank you so much for that and for your time. It's been an absolute pleasure.